Morning. Can everyone hear me?
Yes. How are you, Dr. Gilbert? This is Dr.
Good.
Tang.
Thank you. Good morning for everybody. Thank you very much for having me. So I'm going to start the presentation.
Okay.
And my topic is the transcatheter tricuspid repair, technical procedure and outcomes. And I'll talk about tricuspid valve and valve afterwards. So these are my disclosures. So we know that outcomes of untreated isolated TR is bad. You can see here whether you're asymptomatic or symptomatic, severe TR leads to worse survival and more cardiac events. We also know in the United States, in patients who have mitral clip procedure, if they have severe TR, the 1-year mortality is almost 40%. As a surgeon, we know that only less than 0.5% of TR patients are treated today with surgery. You can see that in the United States, of over 1.5 million patients with moderate or greater TR, only around 12,000 isolated surgical procedures are done. So the principle of tricuspid repair is to ensure leaflet coaptation and mobility, stabilize the annulus, and avoid conduction injury. These are some of the surgical tricuspid repair techniques, the most common currently being annuloplasty, but as you can see here, other techniques have been performed before. And in terms of transcatheter devices, many of them mimic surgical type repair, such as direct annuloplasty, ring annuloplasty, edge-to-edge repair, and even valve replacement. Some of the challenges in device and trial designs in tricuspid repair is that the patient population is relatively heterogeneous. As the previous speaker mentioned, you have to have quality imaging, and the requirement and parameters vary by devices. The anatomic criteria also depends on the type of device, and the clinical endpoints are hard to define. And of course, if you have significant residual TR, it still carries a bad prognosis. So when do we want to do transcatheter tricuspid repair? There is currently no device that's approved in the United States, and it's typically reserved for patients high or prohibited risk for surgery. They also have to have favorable anatomy and good TEE imaging. Patients can have pacemaker or right ventricular leads, but that is not a contraindication. And we avoid severely dilated annulus or poor RV function. Here's a paper that shows a review of good imaging of the tricuspid valve on echocardiography. You can see here also the CT scan outlining the coronary anatomy in terms of evaluating for tricuspid transcatheter repair devices. You can see an example here where a surgical annuloplasty can result in a kink in the right coronary artery requiring PCI intervention. There have been a number of first-in-human experience with the transcatheter tricuspid devices you can see here. And majority of them go from several different approaches such as SVC, IVC, transapical or transatrial, but they typically target the IVC, the leaflets, and the annulus. Majority of the patients right now, this is the tri-valve registry, undergoes the tricuspid repair with the mitral clip device because that is commercial available that they can do off-label versus other devices. However, the coaptation depth is the single most important predictor of procedural failure. If you have a large gap, there's a smaller gap. I have previously published a step-by-step guide with the tricuspid clip using the older generation NT device. And also I'll have to describe using tricuspid clip in patients with previous pacemaker lead that could be extracted and replaced with a leadless micro device. Current experience with tricuspid clip experience is pretty wide, over 600 cases in Europe and 300 in the United States. We've done at least 3 cases in the first time in the Middle East, in Saudi Arabia recently in June. The outcomes do vary by anatomy. This is a patient I will present to you, 89-year-old female who was on dialysis and frail with previous pacemaker implantation and the lead at the posterior septal commissure. The patient could not be enrolled in the Triluminate early feasibility study due to dialysis. You can see here in the TEE view, 4-chamber view showing torrential TR. You can also see in the RV inflow view explain, showing torrential TR and where the gap is and where the leaflets are. This is the beam at the anterior septal leaflets. And you can see here as you go to the same time, and then you can see on the 3D, the pacemaker lead crossing the posterior septal commissure. The transcatheter view, as the previous speaker noted, is extremely important here. You can see here how it looks like on the transcatheter X-plane. You can see the gap present on the right side of the X-plane view with the T. 4D transcatheter is also helpful. This is a 3D volume reconstruction, allowing you to visualize the leaflets better than just plain 2D. One thing, the current Philips system, which is what we use, you can see here, this is the 4D transcatheter multi-view. You can see here in the top right corner, you can explain anywhere on the tricuspid valve to allow you to have a perpendicular intracardiac echo ICE is also helpful. You can see imaging on using the 4D ICE. And you can see here, you can actually mark the specific leaflet. What it looks like on 2D and 3D, helping you with leaflet grasping. Again, you can see here one that was anterior septal, this is posterior septal, and you can even have RV and RA view at the same time. So here's the MitraClip XTR device being in the right atrium, trying to cross into the right ventricle, and you can see on fluoro how it looks like. You can see actually there's another clip that initially when we try to implant, unfortunately, when we deploy the needle interacted with the clip and actually, unfortunately, embolized the clip and was stuck in the right ventricle. Certainly, this is a risk of this procedure as off-label. But you can see here on the grasp in the see after you can grasp a nice double orifice and the anterior septal leaflets. This is the one with color. You can see the residual jet at the posterior septal leaflet area. And you can see on ICE how it crosses into the ventricle and show the nice leaflet insertion upon grasping in the next view here. So you really have a nice image of the 4D ICE avoiding the artifact of the shaft of the clip system. Again, you can use 4D TEE and multi view on the transcatheter left side that you can see the two leaflets together as the clip becomes close and do the echo assessment on color. And you can see here, this is the clip deployed at the anterior septal area. That's what it looks like on echo. And on fluoro, we can see here the second clip going a little bit more posterior septal. And you can see on the transcatheter view how you rotate the clip more in the posterior septal area. And as the clip closes, you see another orifice being formed between the posterior septal and the center. You can see it as you close and the TR is reduced. This is a 4D reconstruction with a full volume look to appreciate the double orifice. You really want to make sure you have good leaflet insertion. And so you can see this is the clip being deployed on the posterior septal. And this is the final result with mild TR with 2 clips. And you can see here with ice as well. And you can see it before and afterwards, what the difference is between before the implantation. And again, this is before on the left side and afterwards the right side. And again, on ice, you can really appreciate how it before from torrential TR down to mild TR. And this is the final floor image on both LAO and RAO view. We also look at hemodynamics. The patient's V wave came down on the right from 35 to 25. Patient was able to dialyze much more aggressively, and she certainly felt really well. And at 30 days, there's only mild TR. You can see here, this is before on the transthoracic echo. This is now afterwards, showing the TR is significantly less than before. I'm going to show the data of the Triluminate trial, which is using the dedicated TriClip system. The 6-month outcome just presented recently at TCT in San Francisco. This is the same clip, which is the NT, which we don't use anymore, but that was part of feasibility trial. We now have XTR and NTR, but the clip system is designed specifically for the tricuspid with a shorter delivery system. And you can see here, this is a safety feasibility study, single arm. And you can see these are the 85 patients that were enrolled. You can see a majority of them are female. They're relatively young at 77 years old. You can see here most of them have AFib, previous mitral intervention. 14% have some kind of right ventricular lead. And you can see here they have a pretty large end-diastolic dimension and very high TAPC. You can see here that what the 100% time procedure is typically around 2 to 2.5 hours. Not a lot of major adverse event, but you can see here cardiovascular, there are 2 patients, one new onset failure versus what we expected would have been much worse. In terms of safety event, you can see and about 20% are posterior septal. There's a device effectiveness. You can see here it was achieved in 87% of the subjects. About 57% of the patients went from to mild and moderate TR only, compared to before where it's only 6%. There's also significant improvement in echo parameters. You can see here in terms of EROA, regurgitant volume, vena contracta, and including even tricuspid inner diameter. So there's also an effect of annuloplasty indirectly from the edge-to-edge technology. You can see here the NYHA class improvement at 6 months and sustained, including a KCCQ score and 6-minute walk test as well. You can see it as possible remodeling on the right ventricular dimensions, right atrial volume, and fractional area change at 6 months. So in summary, the Triluminate early feasibility shows good at the procedural success with no major device safety concerns and good clinical outcomes so far. Now, there's also direct annuloplasty at the Edwards cardio band. You can see here that you can cinch the device directly. This is done percutaneously. And again, there is a deployments in a stepwise fashion. And we just reported again the TCT, a single arm 30-day results. These are the inclusion criteria. And these are the primary endpoints. So you can see it only 22 patients, so smaller experience. Again, most of them are female, and almost all of them had atrial fibrillation or atrial flutter, and about means systolic pulmonary pressure of 40. You can see the procedure is also very safe, with no stroke, 1 coronary artery constriction, and then 7 severe bleeding and 1 access site complication. So the overall technical success around 95%. You can see here at 30 days, a sustained annular reduction. And also in terms of TR severity, was much improved compared to baseline. So you can see here there's significant TR reduction also at 30 days in terms of PISA, ROA, and vena contractor, and good KCCQ score improvement and 6-minute walk test. So the conclusion of this particular device is that initial early US experience is promising with sustained TR reduction and annular reduction, and currently the trial will be expanded shortly. The bottom line is that it depends on the phase of the right ventricular dysfunction the patient is in to see which tricuspid therapy benefit. You can see here if they're early stage, you can consider leaflet device, annular device, or even replacement. But as the patient gets worse and worse right ventricular dysfunction, you can see here leaflet device or annular device will not be helpful, and rather perhaps a palliative cable valve replacement or spacer may be beneficial in these patients. So in summary, untreated severe TR really carries a bad prognosis. Transcatheter repair at its infancy, but the early results are promising. As you can see here, imaging is key to patient selection and procedure success. 4D ICE, in my opinion, complements the 4D TEE during the procedure. And the heart team approach is important too in terms of evaluating these patients and managing these patients, because if we evaluate them early, we can optimize them and perhaps offer them all the different therapies from medical, surgical, and transcatheter. Thank you very much for your attention.